We'll go ahead and get started because I want to give as much time as possible to Professor Kimaiyo and Dr. Gardner, who we really have the privilege of hosting today at MGH Global Health Grand Rounds. And so for you all that may not know me, my name is Garen Stone. I'm the Global Medicine Program Director here at MGH in the Department of Medicine and the Center for Global Health. And it's really my honor and privilege to welcome you all to this month's session where we're hosting Professor Kimaiyo and Dr. Gardner from the AMPATH, the Academic Model for Providing Access to Healthcare. I almost went back to the old name there. Originally founded in 1989 as a collaboration between Indiana University and the Moy University Faculty of Medicine, it really grew up in response to the HIV epidemic in 2001, where the universities launched a treatment program for patients living with HIV. In the following years, it has accomplished so much that we'll hear about hopefully this morning. And looking at through some of the numbers, over 160,000 patients currently on HIV treatment, over 1 million home-based tests from their home-based counseling and testing program. Over 1,600 students have come through the program, and it's really evolved and grown, continually seeking to provide comprehensive care, seeking to bring the full power of an academic collaboration, including clinical care, training, and research to address HIV as well as primary health care, chronic disease management, and specialty care. And it's my privilege to introduce our speakers individually. Professor Sylvester Kimaiyo is the AMPATH Executive Director and the Chief of Party of AMPATH Plus. He's charged with the daily running of AMPATH and lectures at Moy University, as well as rounding at Moy Teaching and Referral Hospital. After graduating from medical school at the University of Nairobi, he spent 5 years at Moy University as the first internal medicine lecturer, then came to Indiana University for further HIV and cardiology training, and during this time helped to launch AMPATH to treat those living with HIV. Within AMPATH and under his leadership, it's expanded to include chronic disease management, including a cardiology clinic. Dr. Adrian Gardner is the Executive Director of the AMPATH Consortium, the Director of the IU Center for Global Health, and the Associate Dean of Global Health at the Indiana University School of Medicine. He received his bachelor's degree in medical doctorate nearby to us here at Brown University. He has a master's in public health from the Harvard School of Public Health and completed his internal medicine residency and infectious disease training here at the Beth Israel Deaconess Medical Center before joining the infectious disease faculty at Brown, where he was from 2007 to 2012, really helping to develop and lead AMPATH's tuberculosis program. In 2012, he returned to Eldoret to work full-time as the Executive Field Director for the AMPATH Consortium until this past year when he assumed the roles I mentioned earlier of the Executive Directorship of the AMPATH Consortium. It's really my privilege to turn it over to you, Professor Kimaiyo, and Dr. Gardner. Thank you so much for joining us today.
Thanks so much, Garen. It's great to see you all, and thanks so much for the opportunity to be here. So we're gonna try and give you we got a little bit of an ambitious agenda here. We're gonna try and give you an overview of the AMPATH sort of principles and partnership, and give you some examples of how the health system can be strengthened in a model like this. Then we'll touch on sort of the impact of the COVID pandemic. Obviously, you can't give a lecture these days without touching on COVID. So, and then I think review challenges and opportunities ahead for global health. And we're going to try and do this. I appreciate the invite for both of us, really, to provide kind of two different perspectives on this, so to speak. Or Professor Kimaiyo and I have done this a few times together, but it's always we always have a different sort of perspective from to share. So I think it's always useful to have both of us here. And I think, hopefully we can describe for you a model that's really a model partnership that's really focused on sort of a goal of equity. In this day and age, there's been a lot of discussion around equity and global health, and I think that AMPATH has something to offer that conversation. So I'll go ahead and get started here, and we'll flip back and forth a little bit between Professor Kimaiyo and I. So what is AMPATH? So the academic model providing access to healthcare, as Garen said, is really a collaboration between Moy University, Moy Teaching and Referral Hospital, and a group of currently North American institutions. There are currently 12 that we collectively refer to as the AMPATH Consortium, that's led by Indiana University. And really the goal of the partnership is really to partner in health and delivery of health services, strengthen the public health sector system, strengthen and develop human capacity through training and education, advance research to improve the health of underserved populations, and improve access to high quality medical care. So really, the tripartite academic mission, leading with care, is sort of our tagline, but creating a atmosphere that fosters education and relevant research. And I think, what's unique about AMPATH is it's not an NGO, it's not a legal entity, it's really just the name of this collaboration, but it is greater than the sum of its parts, if you will. So none of the institutions that are part of AMPATH could do what we do all together. So there's something special about that relationship. So just to give you a sense of the North American institutions that are part of the AMPATH Consortium currently, although this is expanding as we speak, and we'll sort of touch on that at the end here, but these are the institutions that are currently part of the consortium. This is mostly where we work in Western Kenya. So you can see there's a city called Eldoret there with a white star on it, and that blue area is sort of the catchment area that is served by the National Teaching and Referral Hospital, Moi Teaching and Referral Hospital. So it serves as a catchment area of about 20 million people. So I think it's worth reviewing some key principles of AMPATH partnership, because I think I think this is what in some ways makes the partnership somewhat unique, certainly when it was founded back in 1989, 1990. And really, it's important to understand some of the history here that, Indiana University has been part of the fabric of Moi University really since the beginning of its medical school. The first class was admitted in 1990, and Indiana University has had full-time faculty on the ground in Kenya really since that time. So again, just to review some of these principles, I think this shared belief that health is a fundamental right and that a holistic approach is the best way to support the interconnectedness of physical, mental, and social health and well-being. So we really try to take a fairly holistic approach to health. Our programming is designed in response to the needs of the population. So when we say leading with care, we really hold ourselves accountable to the health of the population as one of our key metrics. This partnership is really about long-term engagement. It was not started with a particular 5-year grant or frankly any money at all. It was actually just sort of a commitment to be partners and to see where this would go. We've set ourselves up as really in counterpart relationships with AMPATH host partners leading the way. In this case, Kenyans leading the way in Kenya, and those of us in North America providing sort of support. Philosophically, it's really built on the inherent power of academic health centers, and we feel like there's something inherent about academic health centers, particularly in terms of improving access and care for the underserved populations, that is relatively untapped in places like sub-Saharan Africa. So as I said earlier, that leading with care, but ultimately creating a health ecosystem that enables training and research. We've been fairly deliberate about the way that multiple institutions work together in a complementary way under one united leadership. And that's made it easier, frankly, for our Kenyan partners, and also help us avoid some of the pitfalls of sort of multiple institutions working together with sort of sometimes competing interests. And I think one aspect of the partnership that I'm particularly proud of is sort of the ability to make mistakes and self-correct. I think that's a sign of sort of maturity. That's we have done almost everything wrong the first time, but we're able to sort of self-correct and learn from our mistakes and kind of try again. And I think that, also important is this sort of concept of reciprocal innovation, which is that, we're constantly learning from one another. And frankly, we've got programming here in Indianapolis that is informed by our programs in Kenya as well, and really back and forth. So again, I think, one of the key principles is sort of striving for equity and partnership, recognizing that things are not equal, but we try to maximize mutual institutional gain, as I said, greater than the sum of its parts. We've, in terms of implementation of an equitable model, we've got bilateral medical exchange of faculty and trainees. Again, we all work in these counterpart relationships, creating research opportunities for Kenyans and North Americans. And again, this concept of reciprocal innovation, where we're acknowledging that we're constantly learning from one another. In terms of the way we've, again, organized our North American partners, you can see here that, we have fairly discrete areas of involvement. I know this is a little bit small, but I couldn't even name all the areas in which we partner together with our Kenyan partners across the AMPATH consortium. But I think what we've done is sort of very deliberately have a lead North American institution for each particular area that serves as a coordinating force in a particular discipline, whether that be clinical or in some cases it's public health or biostatistics or something. And that North American partner kind of leads the effort from other North American partners in conjunction with the Kenyan counterpart. So again, in a kind of deliberate way to avoid the the problems that can come up with it, with Kenya having to navigate multiple institutions on the partner side. So in a very brief simplification overview of the program, of the CARE program, just tell you that when this partnership started in 1989, Bob Einherz, my predecessor in this role, served as the first team leader. He was the first team leader in Kenya and was there in 1990 for the first class at Moi. And really the first 12, 13 years of this partnership were built around the idea of helping to build a medical school. So again, there was bilateral exchange of faculty and trainees. There was a lot of faculty development. Clearly, one of the things that Indiana University was looking for was a place for trainees to engage in global activities. But there was really a lot of sort of building, together. And then in 2001, we sort of realized that, we built this nice academic partnership in the middle of the HIV pandemic. And as Garen said, this is really when the term AMPATH was coined, and initially stood for the academic model providing access, for the prevention and treatment of HIV/AIDS, which is what Garen was going to say earlier. So in 2001, we really started treating our first HIV patient through sort of philanthropic funds and getting antiretrovirals. And as Joe Mamlin, one of the founders of this program, really likes to say, he was there in 1992, and then when he returned in 2001, where he had seen about 50 patients die on the wards, he now saw 1,000 patients dying. And again, true to our calling of leading with care, I think we felt responsibility to respond to that pandemic in a way. And I think because we had this sort of already 12, 13-year history of institutional and individual relationships and partnership, and we were able to rapidly scale up HIV services when PEPFAR came in 2004. And I'm going to pause there and let Professor Kimaiyo take over and describe a little bit about the HIV program, and then we'll come back to sort of the more recent history. So, Prof.
Thank you, Adrian. Just to make it easy for Garen and all. So our previous name, we coined AMPATH, but that was academic model for the prevention and treatment of HIV/AIDS, AMPATH. And in 2008, when we got our first NHLBI grant and we were beginning to go beyond HIV, we changed the name to suit the times. We called it the academic model providing access to healthcare. Still, we retain the word AMPATH. This is the geographical distribution of AMPATH in Western Kenya. That is actually the Western Kenya region near Lake Victoria is where most of the HIV in Kenya is. The north is a little arid and a bit of more Muslim, and there is very little HIV there. So it is in this corner where this map shows. And as you see in the next map, 2019, we were, USAID gave us, or we got the opportunity to work in Turkana. Turkana is a semi-arid, very large, very long distance, very difficult place. And we've been working there for 16 months. So overall, we currently work in 11 counties. Kenya has 47 counties with about 50 million people. And the area we are working is about catchment of about 10 million people. And or as you see on the next, is that what is our strength? Now, right now, I am not in my usual place. I am in Western Kenya, just outside Lake Victoria in a town called Bondo. And we are working with a young university. We just got another PEPFAR award for $74 million. It's an integrated program, most of it being HIV in the Lake Victoria region. And so this is a big achievement. I actually almost missed this meeting because we are submitting the questions from PEPFAR tomorrow. And we have a pre-award assessment going on. And the university we are working with is young. We're actually replicating in Kenya what we do in AMPATH. So our biggest strength is the academic partnership. MU, IU, and MTRH together with MOH, and I think Adrian has described that. One of our biggest strengths is the electronic medical record system that we use. This is OpenMRS platform that is now worldwide. We also have the strength of being in institutions of the government of Kenya. Moi University, MTRH is a government institution. The university we are going to be working with is a government institution. We have modeled based on Indiana University, the Research and Sponsored Projects Office. So we don't have much bureaucracy because we have our own financial management system. We run one central nervous system where the whole system is one. And we have a tyranny of numbers, if I may call it. We have, so that with the database and the numbers, we can make any statement by reviewing our database to ask any questions. And that's very exciting. We can write many manuscripts by just looking at our HIV database. Now it has oncology and it has chronic disease. Next. We, at the moment, have several partners under us. We have University of Washington, ITech. We have, of course, Indiana University, and they have another tie with our other colleagues. And then this is a couple of local NGOs and churches that we subcontract to. Next. This is AMPATH Center in Eldoret. The people here are all USAID, AORs or other partners who came to learn, to benchmark what we do in AMPATH in our headquarters in Eldoret. Next. So we do have challenges. And that building I just showed, we build to house AMPATH. In every facility or every county or every population we work, space is a big problem. Nobody budgeted for HIV, nor built for HIV. So using all sorts of money from philanthropy to PEPFAR at the beginning, when they could allow, we expanded HIV space. And I'll say right now that that same HIV space is what is housing oncology, chronic disease, and research. And staffing in Kenya is a major problem. We don't have enough staff in the county. So we have had to use PEPFAR and other donor money to add staff to meet the challenges of HIV. And we have to struggle with staff morale, burnout, transfers. We had to create our own testing platform with our first CD4 machine donated from a friend of Indiana, Joe Witz. And the initial ARVs that Adrian described when we started were all collected and donated from the US, led Indiana's friends and so on. And record keeping, we've sorted out by OpenMRS. Our patients, many of them don't have enough food. And then there isn't much food in the ARVs. So we often have to also give food as well. But we have our model, research follows care. All these things, we have to do care, we have to do research as well. I mean, it's an opportunity that just comes. Where the more care we do, the more research dollars follows us as well. Transparency, accountability, some of the, a lot of challenges out here in terms of maybe corruption or other things and how to use the money. And we always have to work on exit and sustainability plans. We know that PEPFAR is not forever and donors are not forever. So we are working on all those which we can refer to later. So I will not want you to go through this organogram, but this organogram speaks to the recent changes where AMPATH reports directly to Moi University Council, which is the board, and the MTRH board, and how we fit into this. We have a committee, an executive committee, we have a subcommittee. I'm currently the acting director of executive director for care. I have a colleague for research, and then we have several. So we do have a structure that works for us. Next. And this is what Adrian referred to. Ever since 2001, we are ever enrolled almost 300,000 patients into HIV, our HIV clinics. However, next, you'll see that not all have stayed. And the reason is some we have lost to follow-up, but more important, when we started these clinics, we were the only clinics that people went to. For example, our clinic in Kisumu, in Chulaimbo, was the largest clinic in the Kisumu area or in the Lake Victoria area. But as more clinics come, these patients go to those newer sites close to us. So currently we are taking care of about 170,000 patients, starting with one patient in 2001. And now with the award we just received, we are going to add into the system almost another 100,000 patients. Next. This is a cumulative AMPATH research and training grants awarded since the beginning. And most of this is NIH funding, particularly from NIAID, that is ACTG and other trials. And you can see as our care grows, our research dollars also grow. Hence, we have, our motto is AMPATH leading with care. So we do lead with care, but we know where we are going. Next. And in it also, in it also follows our publications. As we get more research, we have more publications. And as we go forward, we are realizing that we have to integrate our services. And so we are leveraging in these same facilities. I talked about space. I need to talk about transportation. I need to talk about electronic medical records. So we are layering the chronic diseases on our HIV services. For example, you have MCH services are being layered on these. These are the same people, same behavior, different doors. We really are working very hard to integrate these services. Our current PEFA grant that we just won is an integrated mechanism of HIV, reproductive health, MCH, FP services, orphans and vulnerable children, and health system strengthening. And this is going to take us into the future in terms of sustainability. Next. And what we say is that there is no better time to combine our efforts than now, and working together achieves more. So that's like giving you a very small nutshell of our HIV program and how it is integrating. I'll let Adrian talk more beyond this. Thank you very much.
Thanks, Prof. So as Prof. Kimaiyo said, I think, when we launched the HIV program outside of the Moy Teaching and Referral Hospital, where the partnership was initially, we followed the lead of Moy University because they had established a medical school that was very much committed to community-based education, and they had a relationship with some of the health centers. And so we were able to sort of jump upon that relationship with these local health centers and smaller level facilities and take advantage of that and offer an HIV clinical service as part of that under the name of sort of Moy University. And as Prof said, we've obviously scaled up those HIV services. Now the challenge is really, how do you sustain this? How do we take the investment that PEPFAR has put in Kenya and many other countries and really leverage it in terms of a broader health system strengthening agenda? How can it be that, the chronic disease clinic? Really, before PEPFAR, there was no infrastructure for chronic disease care. You essentially walked into a health center in many places in sub-Saharan Africa, you're either a maternal child health patient or you're acute, what in Kenya we call the filter clinic, acutely ill, and you sort of get your prescriptions and move on your way. So what PEPFAR has really done is create a whole new platform for chronic disease care that really can be leveraged not just for HIV, but for management of hypertension, diabetes, cancer, chronic pulmonary disease, mental health. So we have to find ways to take this sort of again sort of siloed enormous level of funding for HIV and try to broaden it into a platform that can care for sort of the health system more broadly and the population more broadly. So that's kind of what our next chapter has been really since 2008. We've been focused on kind of this what we call our population health and universal health cover model, which is really trying to take the investments we've made and the comprehensive approach we've made towards HIV and try to leverage that to to a broader set of the population, not just the sort of 5% of the population that's infected with HIV. And so we've been able to focus a lot of this effort on social determinants of health. So we have microfinance groups in the communities. We work with almost everyone in Kenya, in Western Kenya, is a farmer of some sort. So we do a lot of work around agriculture and economic and social empowerment. So really, AMPATH works across the spectrum of the health system. So really at the, I guess, as I said, at the lower levels of the health system with health promotion, screening, primary care, a lot of this focused on the social determinants. We provide all within a Ministry of Health framework, primary care services and maternal child health, NCDs, obviously TB and HIV and mental health. And then at the same time, really building the specialty capacity of the National Referral Hospital. And again, I can't even name necessarily all the ways that we differ. The partners in North America partner with their Kenyan counterparts. But oncology, hematology, cardiology, nephrology, infectious disease, palliative care, adolescents, pathology, dermatology. There's really almost no specialty you could name that has some sort of collaboration of some sort or another, and it goes beyond the medical school. So nursing, dentistry, public health, nutrition, and agriculture, and even engineering. And then obviously to support some of this care delivery across the health system, there's been some cross-cutting investments in pharmacy and supply chain innovations. As Prof mentioned, the electronic medical record system has been key for us. So again, from a little bit from a North American perspective, we've had full-time faculty in the departments of medicine, pediatrics, surgery, and OBGYN, and oncology from Indiana University and some of our partners, University of Toronto in particular. And then lots and lots of short-term faculty engagement. So I just want to give you kind of a sense of the scope of this partnership over the 30 years. We've made significant investments in infrastructure. Professor Kimaiyo mentioned the HIV building, but this blue roofed building you can see is actually the Chandaria Cancer and Chronic Disease Center that was largely built with philanthropic dollars through Indiana University. And serves as really the referral center for all sort of chronic disease care, including cancer. And now, as of a week or two ago, is now doing radiotherapy. We've been waiting a long time for that, but we actually have a linear accelerator now providing radiotherapy. So that's very exciting. But we've helped build a Riley Mother Baby Hospital that does about 10,000 deliveries a year. Primary care. Some of the rural health centers, buildings dedicated initially for HIV, but now serving broader than just HIV. Operating theaters is a adolescent clinic, and actually the most recent infrastructure project that's just being sort of underway is a transitional home for individuals with mental illness at Moy Teaching Referral Hospital. I think importantly, as Professor Kimaiyo said, also in terms of infrastructure, is the sort of research and sponsored projects office, which is really a grants management organization. And in some ways, it's where AMPATH becomes the most real because it's really a standalone grants management shop. So it has HR and finance and compliance and all the different aspects of grants management, and operates a little bit at arm's length from the hospital and the university, although ultimately accountable to the CEOs of those institutions. So it's really allowed AMPATH to be set up in terms of a way of capturing extramural funding to help support the regular budgets of the hospital and the university. So again, from a North American perspective, obviously what's been important for us as North American partners is the opportunity for trainees to engage. So we've had over 1,900 medical and pharmacy students from North America. You can see over 600 medical students and 460 residents from IU have rotated through the program. Some of the work that Garen was involved in, I had to put these papers in because Garen, when he was team leader, was involved with actually getting some of the funding to support a formal sort of assessment of the impact of some of these trainee experiences. So we've demonstrated that participants of the AMPATH exchange program are found to be more likely to provide care for underserved populations and consider care in their clinical care decisions. Obviously, not necessarily a what comes from causal relationship here necessarily. I mean, it self-selects for people that are interested in these things, but nonetheless, I think it helps in terms of the medical education. And in some of this qualitative work, people have really described, students have really described this experience as transformative in terms of giving themselves a broader worldview and the impact suffering and death in particular. And so we have a fairly strong curriculum that we help trainees sort of walk through when they're there with full-time faculty on the ground. We've also got opportunities we got a Slumendus Scholars Program for students between their first and second year of medical school. And then many medical students have participated in more sort of year-long experiences sponsored by Fogarty, Doris Duke, and other fellowships as well. But as I said, that the street goes two ways. So we've developed educational opportunities for Kenyans. Again, we've had a long faculty presence really that's been integrated within the Moi University structures and help with teaching of Kenyan medical students and residents. Since 2007, there have been over 10 residency and fellowship programs that have actually started. Actually, fellowships never really existed before in Kenya. So we've had the first fellowship training programs established in gyn-oncology, maternal fetal medicine, cardiology, peds oncology, and oncology sort of not far behind, as well as the first clinical pharmacy residency program under the leadership of Purdue University, which leads our consortium in pharmacy. In addition, we provide 75 full tuition scholarships for Kenyan medical students with financial need to attend medical school at Moi University. And over 340 Kenyan medical students have been hosted in North America for in their 5th year elective period for clinical rotations, and close to 50 registrars as well. So again, we've committed to this sort of bilateral exchange of medical trainees. It's not just one way. There's also been other educational opportunities for Kenyans. We've had for clinical officers, or sort of the mid-level providers, advanced practice course to provide them with additional skills on chronic disease management. Lots of faculty and staff opportunities to refine clinical skills, and obviously research training for faculty, including D43 grants and NCDs, biostatistics, HIV, and cervical cancer. On the research side, again, the Research and Sponsored Projects Office, we've talked a little bit about. We have an AMPATH reference laboratory. This partnership has helped to bring up an institutional research and ethics committee that's based at the university and the hospital. We have working groups that provide a forum for collaboration and really a robust set of research SOPs where there are counterpart relationships established and a publications committee that reviews things and with an eye towards sort of equity, as I said. So I won't go through all this, but this is sort of the way we've structured our research program. So again, a North American and a Kenyan lead, and you can see various working groups that serve to sort of vet and discuss proposals in various areas. And in terms of the metrics that deans care about, the research program has done very well. So as Prof. Kimaiyo mentioned, $180 million in research awards. Over 970 publications out of this, and more than 70 active studies. And I think importantly about the research, the research translation is that as a body that sort of addresses the tripartite mission, we have an opportunity really to take some of these lessons learned from our research and apply them in care delivery. Not that that's necessarily easy to do, but and we certainly haven't done it right always the same the correct way, but we have care delivery programs where we foster the connectedness of care training and research leadership and missions. I think that as an academic body, we can relatively easily incorporate some of the findings of our research into curriculum, foster lifelong learning, and obviously publications. And over time, as Moi University as a government institution, a lot of the experts that have been brought up in Kenya have joined policymaking bodies in Kenya and really around the world to help inform policy creation as well. So I'm going to pause there. I'm going to shift gears a little bit because I think we have to acknowledge that these are obviously challenging times for global health efforts. As you all know, we've stressed health systems in much of the world. The pandemic has forced closure of educational institutions, disrupted the global economy, shut down or forced redirection of research, certainly restricted travel, forced institutional budget cuts. But I would argue really that never has the interconnectedness of the global community and the need for global cooperation been more obvious. Right? And so we've had to adjust over the last year to the pandemic. And we've tried to do so in a remote way. So we've continued some of our strengthening health systems. Again, this is sort of a North American perspective on this, but But I think importantly to recognize, first of all, is that Kenyans obviously led the effort to respond to COVID in Kenya, and part of this partnership has strengthened those institutions and those individuals to the point that they, Kenyans lead all of these programs. Really, it's just we provide some support. So in terms of our remote support for Kenyan colleagues, we had, we can sort of characterize it as COVID-19 response, and then support ongoing service delivery and education and research. And then as the Center for Global Health, I won't necessarily go into this, but we've played a role here in Indiana, leveraging our experience in pandemic response, so to speak. Just to briefly go through the way this is played out in Kenya. So the first cases were on March 13th, 2020, just about a year ago. Interestingly, for some of the early cases of COVID-19 were actually diagnosed among truck drivers, so very similar to the way the HIV pandemic was discovered and spread across East Africa. Kenya really got an early jump on this. I mean, they were kind of late to the COVID game, and were able to shut things down pretty aggressively. And I'll go through this, sorry. Institute early mitigation and travel restrictions. Because of the HIV investments, they were able to rapidly retool HIV laboratories into COVID diagnostic centers. Global funds were redirected, and then at a more local level, the Moi Teaching Referral Hospital developed a COVID task force and established a home-based care effort, as well as training and preparation for inpatients. So let me go back here for 1 second. So, but unfortunately, as the rest of the world, Kenya tired of the restrictions, and the economy started to take a downturn, and so international flights resume, and you can see sort of the changing curve. And then by mid-October of last year, restrictions eased further, and you can see another sort of surge in the pandemic. So again, you all know this because I'm sort of preaching to the choir here, but how do you socially distance when you live in a place like this, or you get your water from from a place like this, or you have to take one of these to get to work in the morning? How do you physically distance? Or even, in fact, if you get sick, if you're in a hospital bed like this, where you really can't distancing from the person next to you, right? So overall, Kenya has seen sort of a similar kind of pattern that we've seen in the rest of the world. We've had these surges. But look at the total numbers here. We're talking about 106,000 cases and 1,800 fatalities. They're not even on the same scale as we've seen in many other parts of the world. Now, obviously, a lot of that is underdiagnosis and poor access to diagnostics. Part of it is likely driven by the fact that Kenya has a median age of 20, about half that in the United States. And so many people have probably had asymptomatic disease that's gone unrecognized. But interesting that there's some speculation about cross-reactivity of other coronaviruses and other things, right? So ultimately, though, Kenya did suffer from this, right? With significant shortages in testing commodities. There have been inadequate supplies of PPE. There was certainly a lack of dedicated inpatient and ICU space. And infection control, as you can see from those pictures, is clearly lacking. And there were many healthcare worker infections, over 30 deaths of healthcare workers, which is obviously enormously impactful in a place like Kenya. And many of our Kenyan colleagues actually had to, had issues with their medical cover, actually, because their insurance providers actually invoked the pandemic clause and said, well, that's, the pandemics aren't covered under your insurance. So if you get sick with a pandemic virus, then you can't have your inpatient stay covered. But anyway, so again, to go back from an IU perspective, we provided PPE and testing commodities and clinical equipment. We got some pulse oximeters and UV machines for mass decontamination over to Kenya. There was a lot of work on the AMPATH Consortium side to train and provide sort of a forum for virtual support for Moi University training programs. And then studying that and understanding that and mitigating the impact on service delivery locally. And then we're in actually the process of doing sort of some cash transfers for some of the neediest patients in terms of some of our microfinance groups and the HIV patients. All this is required on our side, sort of redirecting existing program and philanthropic funds, and our development team's been busy trying to raise the funds to do this. But I think, unfortunately, the worst may still be to come, because I think perhaps more devastating than the direct effects, maybe the indirect effects that we see of this pandemic for years to come. So this is a paper from the Lancet that predicts that, over the next 5 years, mortality could increase by 10, 20, 30% from HIV, TB, and malaria just from interruption of the health service delivery. And obviously it's not just infectious diseases, but really, across the spectrum of the health system, routine immunizations, NCDs, family planning, all these have, shutdowns have forced sort of major breakdowns in the systems. And again, it's not just health systems, right? It's the economy, right? So preliminary estimates are that, the economies will suffer sort of a 1.4 to 8% contraction, and another 30 million people could fall into poverty. And Prof mentioned, acute food insecurity we're seeing in Western Kenya as well. So this is going to require expansion of social welfare systems in a way that's, so never really been seen before. In terms of a little bit more sort of local data, this is preliminary from a cohort of HIV patients that we have in one of our research programs where we did phone surveys. Fortunately, almost all the patients were able to access and adhere to their HIV medicines. But interestingly, a third experienced worsening or depression and anxiety. And we look at the economic impact, half of them had lost income, 60% reported food insecurity, most or some of the time. So again, I think these are some of the long-term consequences that we're going to feel for years to come. So not to be too depressing, there's obviously hope for the future. I think we've seen rapid vaccine development in record time. And I think with the US government recent commitment to COVAX, Kenya is on the COVAX list. So in fact, I just saw a WhatsApp come through not too long ago that the AstraZeneca vaccine arrived in Kenya today. So at least there's some indication that things are moving. But we have to acknowledge, I think, that we have not done well as a global community. This is sort of the latest map on vaccine rollout in terms of equitable access to vaccine. And there's that gray continent in the middle there that has no data, but really has no vaccine, right? And we need to continue to be advocates for those kind of global health inequities that are, that are a major problem. So I'm going to try and finish up here, just to reflect a little bit more broadly. So I think, as a global health community, we have a responsibility and an opportunity really to assess and document the impact of COVID-19 on health programming, even as we strive to limit the damage. I think we have to acknowledge and document global inequalities and work to correct the underlying injustices that drive them. Again, there's been a lot of discussion around that recently. Advocate for equitable access to diagnostics, therapeutics, and vaccines. Obviously, supporting innovation has been, telemedicine has really sort of taken off in the United States, and and developing models like that in Kenya as well. And from an educational perspective in global health, new models of engaging trainees in global health programming. So, I think we have a case to make that, preparing for the next pandemic, if you look at our history with pandemics as a global community, we have about 18 months of time when people pay attention, and then we sort of say, probably won't happen again. Or so, I think we have an opportunity here to respond, and obviously from a global perspective, there's a lot that needs to be done, right? So we need surveillance and early detection systems. We need rapid global response teams. Investment in research and development and clarifying regulatory pathways, and a team of trained personnel that can be mobilized on short notice. But I think I'd also sort of argue that partnerships like the AMPATH model have a key role to play in strengthening health systems and the primary care services and building that trust that's so important in terms of a pandemic response as well. So, it's one thing for, we saw this in the Ebola outbreaks in West Africa. If people don't trust the health system, then they won't seek care there, right? And if you go to the health system and you can't get a regular care for an infectious disease, you can't get a blood culture, you can't get, temperature checked, then there's a lot of things that need, that stand in the way of a sort of a robust pandemic response. So the last plug I'll put in here is that, the AMPATH partnership is actually replicating. So we've secured the funding to actually launch replications of the AMPATH model in Ghana and in Mexico. And we're doing that through existing partners within our consortium. So NYU will be our lead institution, partnering with the University of Development Studies in the north of Ghana, in Tamale, Ghana. And then UT Austin will be leading the partnership in Mexico with an institution called BUAP. I'll spare you my Spanish accent, but we're excited because the leaders of the global health efforts at NYU and UT Austin are actually former team leaders in our program as well, and so that they're sort of brought up in the AMPATH spirit, if you will. And so we're seeking to sort of replicate the model of partnership, not necessarily the programming. The programming will be responsive to the needs of the population there. So I guess in summary, hopefully we provided a description of the AMPATH model that provides a framework for global health partnership that strives towards equity. I think just the challenges that lie ahead are significant, but so are the opportunities to make a difference. So pause there.
Thank you so much, Professor Kimaiyo and Dr. Gardner. It was really just incredible to see that whirlwind view of the partnership and the AMPATH program and all that you've accomplished there. I want to invite the participants to put in questions either into the chat or to the Q&A, and I'll help moderate some of those to Professor Kimaiyo and Dr. Gardner. Maybe as a sort of to get the ball rolling as our participants are putting the questions in, Professor Kimaiyo, I would love to ask you, one of the unique things I've noticed and you spoke about today is the relationship that AMPATH has to both Moy Teaching and Referral Hospital, the Ministry of Health, and Moy University, the Ministry of Education. And I would love to hear from you about how you sort of see yourself. I remember that org chart, the organogram, and how AMPATH sort of straddles those two spaces and what you bring to that.
Thank you, Garen. I think that is actually one of our strengths, to be able to juggle between the Ministry of Health, that is Moy Teaching and Referral Hospital, and Moy University, a Ministry of Education. Each has a CEO, each has a board, and then to work as closely with the Ministry of Health you know, the Ministry of Health is a tough place, you know, a lot of shortages and so on. And to be able, as some of my colleagues describe, be in bed with them, as it were, and work together. And this itself is sustainability. Because in the event that, first of all, like now our current funding that we are coming into, Moy University is very excited about it because we made it as Moy University. And so it has increased our visibility, and it also gives us the opportunity to win whatever grant or cooperative agreements that are put there. So I see this as a very big strength. However, we have to do a lot of education. When we got an OVC award, Moy University was celebrating. They have 38 million US dollars. And I just told them, wait a minute, this is not your money. This is for Moy University to support the communities. So it takes a lot of sharing and education, but I think over the 22 years or so I've worked, I think we have made a lot of, you know, impact both ways, in both where we work in the ministry and Moy University's name of what it does, as well as the university.
That's great. Thanks for that response. And maybe Dr. Gardner, for you, so sort of in line with that, is I think academic medical centers in the US are often very focused on training and education, and a little bit less so on the patient care always, and leaving that to largely the hospitals in many ways as well. But yet your tagline, your mission is leading with care. And I'd love for you to speak to, you know, based out of a university, how do you make those worlds sort of meet?
Yeah, that's a good question, Garen. You know, I'm trying to channel Joe Mamlin here. Just don't tell them what you're doing. So, you know, I think that, you know, obviously what we've found is by, you know, leading an authentic effort to improve the care system, you really do create an environment that is ripe for, you know, relevant education and research. And I think the reality is that if we had come in to this partnership with a research agenda, it probably wouldn't be where we are today. You know, I think that it really was individual and institutional relationship building and a commitment to that leading with care mission. And really just, you know, initially it was literally Indiana University saying, we're going to put boots on the ground and we'll help you take care for your patients and teach your students. And we'll sort of see where this goes. And I think we've always had faculty on the ground that have embodied that spirit. And I think that's been really critical to the authenticity of the program, and allowed others to take advantage of that, you know, and build on those relationships to conduct relevant research and educational programs, but maintaining that commitment to care. So, you know, as you suggest, I mean, the deans and academic institutions care more about the research dollars and the, you know, publications that come out of collaborations like this. But I think it's pretty obvious to everybody at this point that you know those things have been enhanced by the commitment to the care mission. So
that's great. Maybe a follow-up question to that is that, and I'd love to maybe hear. We'd love to hear from both of you with respect to the equity and how you built that in. I know you mentioned that within the talk about the working groups, thinking about publications and research, making sure that it's really equitable. But I'd love to hear about the reciprocity and the equity and how you built that structurally into the partnership.
Prof, you want to start with that, or? Oh, it looks like you froze.
I think you maybe, yeah, I think we may have lost Professor Kimaiyo.
So, you know, I mean, I think oh, you're there, Prof?
Yes, I'm there. I don't know if you can hear me.
Yeah, we can hear you now.
I think the internet is a little unstable, but I want to say that in 2002, we spoke to this in terms of what exactly, how, you know, I actually made a sentence that time because I complained. I was seeing the North Americans really moving with all these research projects so fast, and we couldn't catch up with them. I said, now, what do we do? But right now, it's just flipped, and we are together. So it was a question of capacity building, and now we get equity. It is quite equitable in terms of with the principal investigators or the teachers are either, you know, they're just mixed, and we are all running in it together. So we decided to do it, and we have actually succeeded in having equitable distribution of any of those activities. Take publications, for example, 202, at just one publication. Actually, when I came to Indiana, I had 0. But now, when I went for promotion, I was told I was overqualified. That's the same as my colleagues, you know, in terms of publications. So it has worked well. Adrian?
I think, yeah, I mean, it's fundamentally, we built this into the, you know, the counterpart relationships at all levels. So, you know, our North American medical students are partnered with Kenyan medical students, the residents with registrars, faculty with faculty counterparts. And, you know, I think that's been fundamental in the model across the missions, frankly, not just the research mission. But, you know, we've had to be a little bit more deliberate in terms of the research because, you know, these issues come up when you've got lots of, don't take this the wrong way, but egotistical North American institutions, you know, sort of trying to compete for grants and things. You know, you've got to have a forum where those can be sort of worked out, and partnership and collaboration can be very deliberately sort of you know, kind of fit into the formula there. So you know, I think that's really been the approach.
One of the participants was raising the question, what could the U.S. learn from AMPATH about addressing health inequities that are tied to outcomes, health outcomes? And so what can we take back, or what can we learn from this and apply it maybe here? Yeah.
Well, I mean, the first thing is to acknowledge that we have a lot to learn. We have a lot to learn in our, you know, health systems. And I think, you know, clearly COVID has been another example and sort of highlighted the inequalities that exist in American medicine. You know, we've got a number of examples of actually health programming that have been sort of modified and implemented here. Probably the best example is a project here we call We Care, which is run by Deb Litzelman, who's head of our education efforts within the Center for Global Health. But it's really a community health worker model applied to women in Indianapolis that are at high risk for poor pregnancy outcomes, and focused on infant mortality and trying to reduce infant mortality. And it's really kind of similar to, you know, the PIH model of sort of accompanying people to care, but you know, trying to address social determinants of health and help people help vulnerable populations navigate the health systems. And it really is based on sort of similar models that we've, you know, had in Kenya for many years. So, you know, and in terms of the, you know, the COVID response, we were actually, the Center for Global Health was tapped to sort of respond to the contact tracing effort for Indiana University. So we've been busy supporting the pandemic response here within, you know, IU is a big institution, 120,000 people across 9 campuses across the state. And so we've been involved in some of the contact tracing effort around the state of Indiana. Again, applying lessons learned from sort of global settings and pandemic response. So.
You know, I'm told, I don't know if this is a good thing or a bad thing, that is that when the North American student and faculty rotate in Kenya, when they go back, they order less orders than they used to do before. So I don't know that they get to have their clinical skills sharpened and realize they don't do as many orders as they usually do. I think that's a good thing. Get
I think,
more specific.
Yeah, I mean, I think as you know, Garen, right? Like there's, it's very easy in North American healthcare institutions to feel like you're really busy ordering tests and, managing patients and trying to get them out. And, and I think that, one of the things you learn very quickly when you come to Kenya is, in places like Kenya, is, you see the social determinants sort of smack you right in the face, right? So your patient cannot get an X-ray because they don't have the funds to pay for the X-ray. And, those lessons I think are, ones that we've never faced here, frankly. And I think that they're lessons that people do sort of incorporate into their, their experience moving forward, as Prof said.
Great. Maybe one more question I would love to hear from both of you is, I know you spoke to the future of AMPATH replicating. I would love to hear what you see as the future of AMPATH in Western Kenya, though, and sort of where you see the program with PEPFAR and non-communicable diseases and social determinants of health. If you could look in the crystal ball after COVID or moving forward in COVID, what will it look like?
Now, I think the inherent power of academic medical centers, I think in this, we had a rotation again, as I said, of PEPFAR wards. And the University of Nairobi won 2, and AMPATH won 2 more, but working with academic medical centers. Thereby, actually, we've been talking about replicating the big AMPATH, but we're actually finding very exciting replication within locally in the universities in Kenya. And with the use of the universities, there comes in more power of solving our internal problems and our infectious disease and so on. So for example, Masinde Muliro University, which we also work with, have the COVID response team for some of the Western counties, governments here. So it's actually, we didn't really deliberately see this replication. We seem to have thought of replication now after many years, but it seems to be creating a lot of sharing and a lot of supporting the younger institutions to respond to their communities.
Yeah, and I think, just Prof alluded to this earlier, but I think, one of the big challenges really is to convert, the PEPFAR investment into something that's more sustainable for the health system. And no one's quite figured that out, right? We know PEPFAR is not going to last forever. So the question is how can you integrate without losing, the HIV outcomes that are so, critical, but allow that investment to help strengthen the health system so it can serve not just, a small fraction of the population, but really the health system more broadly. So.
And we had a question come in from one other participant about, is the only way to expand AMPATH only with academic medical centers? And any thoughts about partnering with private organizations in other countries outside of Kenya?
I think, first of all, when I was doing my presentation, I showed a battery of NGOs and faith-based organizations that receive support through AMPATH. And that involves also capacity building those organizations to be able to serve their populations and the problems of their population. And this goes through not just the health equity, it also goes through income generation activities, better farming methods, and linking to our other supporters like Dawa Sciences and others in supporting the Kenyans to be able to have their own sustainable income and be able to go forward. Our biggest hope here is universal healthcare. UHC and national or NHIF or National Health Insurance Fund that is universal, so that we have an insurance that is universal. We see that as a hope into the future, starting with where we have started.
I mean, I think there's no question that the private sector has an important role to play, but I think that, you know, the model has been to strengthen the, you know, the public health system. And as Prof said, we've got, you know, we're now deeply sort of embedded within the National Hospital Insurance Fund, which is the government parastatal charged with health insurance in Kenya. And actually next week, sort of launching a pilot of a UHC model in part of Busia County in Western Kenya. So, Darren, I know we're out of time, but if I can make a pitch, and we are looking for a team leader starting in July. So if there's anyone who's interested in joining our team in Kenya who's on the call today, we're just trying to get that position through the university in terms of approval. We've got, as you know, a couple of MGH connections already in our program in Kenya. So.
Well, thank you both so much, Professor Kimaiyo and Dr. Gardner. It's just really fabulous to hear from you and to hear about the academic model collaboration that you have led and built there. And so thank you so much for joining us today for Global Health Grand Rounds. And everyone, we invite you back. Next month, we'll have Catherine Flowers, who is a rural advocate and leader for health in Alabama, joining us. And we look forward to that session. So thank you all so much and have a great day.